Hyperprolactinemia and drugs. Antipsychotic agents are the most likely psychotropic agents to cause hyperprolactinemia. If dose reduction is not possible or not effective, then MRI to exclude a prolactinoma and treatment of hypogonadism may be indicated. In cases of macroprolactinoma and a history of psychosis, dopamine agonists can be initiated at a low dose with slow dose escalation. The patients will require careful monitoring for the rare complication of worsening of psychosis. Alternative management options include observation, gonadal hormone replacement, and surgery. Where dopamine antagonism is the mechanism of action of the drug, then dopamine agonists may reduce efficacy. Furthermore, antipsychotics may blunt the effect of dopamine agonists on the prolactinoma, and in such cases, aripiprazole, an agent with less of a blocking effect on the D2 receptor, could be considered if appropriate. Drug-induced increases in PRL are usually 3000 μ/L. Management of drug-induced hyperprolactinemia. In a symptomatic patient with suspected drug-induced hyperprolactinemia, we suggest discontinuation of the medication for 3D or substitution of an alternative drug, followed by remeasurement of serum prolactin. Discontinuation or substitution of an antipsychotic agent should not be undertaken without consulting the patient's physician. If the drug cannot be discontinued and the onset of the hyperprolactinemia does not coincide with therapy initiation, we recommend obtaining a pituitary MRI to differentiate between medication-induced hyperprolactinemia and symptomatic hyperprolactinemia due to a pituitary or hypothalamic mass. We suggest that clinicians not treat patients with asymptomatic medication-induced hyperprolactinemia. We suggest use of estrogen or testosterone in patients with long-term hypogonadism, hypogonadal symptoms or low bone mass, related to medication-induced hyperprolactinemia. We suggest that the first step in the treatment of medication-induced hyperprolactinemia is to stop the drug if this is clinically feasible. If this is not possible, a drug with a similar action that does not cause hyperprolactinemia should be substituted, and if this is not feasible, to consider the cautious administration of a dopamine agonist in consultation with the patient's physician.